have any questions before Dr. Fini starts, feel free to put them. Okay. Okay. You want them to put them in the aisle? Okay. You can just put them in the aisle and Alan Levy will collect them.
Well, thank you, Sylina and Westport Republican Women for bringing us all here today. I think that what I can bring to this discussion is the perspective of someone who has medical knowledge but has been on the, the extended mommy nap and ready to go back into work, and now I'm faced with a really different scene going back into work. This is not what I bought into when I went to medical school. So I decided to download the various bills and read them while I was on my little mommy nap. And what I read was stuff that didn't make me very happy. So I decided to go further and do more research. I went to, So I went to the Congressional Budget Office documents and the Congressional Research Service documents and the Government Accountability documents, really fun stuff when you're dealing with my crazy children anyways. And what I found was that the bill, while giving language to expanding coverage, it also gave a lot of language that made me concerned that the coverage would not actually end up with increased medical care delivery. And I found that really bizarre. So I went through it a number of times, and what I kept finding were certain themes coming out in the PPACA, with the theme of penalties, the theme of fees, regulation and data collection. There are 159 agencies that the PPACA actually creates. The crazy thing is that the legislation gives those agencies the authority to create more agencies. So, when they start saying that they can't really figure out how much it's going to cost, they really mean they can't figure it out, because next year they might create another 2 or 3 or 4 or 5 dozen agencies, and all that is going to take more of our tax dollars and funnel it away from care delivery and into the creation of more bureaucracy. So we have the cost, the rationale for it, and it clearly states it in the legislation, is to bring cost of care down, when in reality it spins it way up. And the reason why it spins it way up is because it creates more government bureaucracy and personnel. It does not do very much to deliver more care to you. How does it do that? Well, we mentioned Dr. Gottleib. I was going to say Scott is my husband's name, I can remember that. Dr. Gottleib mentioned the iPad board. This board in particular is really, it's a sneaky, insidious, devious kind of board, because the language in it that creates it is such that it issues recommendations to Congress. But PPACA actually gives the authority to the Secretary of Health. As soon as those recommendations are made, she's got the authority to implement that. So what does that mean for you? Well, that has some pretty significant ramifications for the patients. Forget about, for us and the industry and all this other stuff. What does that mean for your health care delivery? That means it's really completely Secretary of Health centric. Whatever this board tells in its recommendations, that's it. Congress does not have oversight to this board. In fact, it's so sneaky that in a certain section, it gives it's like a 3-month window in 2017 when it can be repealed. That's it. That's it. Why would anyone in Congress who's looking out for us, why would they allow that to become law? There's no repeal There's no oversight. There is no judicial oversight. This thing is like the worst of any kind of megavirus because it's awful. There's not even a word in my my vocabulary because I've been hanging around my 4 kids too long. So we go from a model of care that's patient-centric right now. It's flawed. There's no question about it. It's flawed for the physicians, and it's really flawed for the patient because, as physicians, as a mother of a child with special needs, which is why I've been on my long now, but she's doing well, and now the second of my 4th kids is in college. Time to go back to work. I have been on the other side of the fence dealing with poor care, dealing with a hospital that I just would love to sue, that I won't mention which, dealing with big deductibles, and you gotta pay the bills. We haven't gotten to that point, thank God, where we would have to declare bankruptcy, but that happens to people. What a horrifying shame. What a horrifying shame. And it makes me think back to the day before there was this health insurance. What did people do back in the day when they bought, I don't know, did you ever see To Kill a Mockingbird where Atticus is getting paid by like truckfuls of apples? People worked it out, so I think that I think there's still those instances where hospitals and people work it out. That awful Batman comes back, whatever the heck the name was, with that terrible shooting and all this, the hospitals, they ate it. They didn't charge those people. So it can be worked out. And I think that when it's person to person, that's when it can be worked out. When it's person to government, I don't really think there's going to be too much worked out. That's what I worry about. I worry about going back into practice, being this feisty Italian. I know I'm going to disagree with the Secretary of Health, whatever she says, because I'm going to want to do what I think is right for the patient. Then I'm going to go to jail. I know it. And I'm not going to have a resource for that patient. Hard enough when I was in practice, when I had to go to bat for my patient with insurance, and I would. But at least I didn't have to have that additional fear, not only getting sued, but also of losing my license and of getting my rear end hauled into a court somewhere or jail. So I think there is a significant amount of stuff that we didn't anticipate having, the least of which is the actual language of the legislation. The last thing that I would like to mention also, which Dr. Gottleib touched on a bit, was the state exchanges. Well, my understanding of the state exchanges is that, to qualify to even be in the exchange, the insurance companies have to cough up a plan that's going to cover what the PPACA says is, that we should have as care. And then, as Dr. Gottleib mentioned, there's going to be certain rules where, like if you have a certain amount of income, you get either a credit or et cetera. But I think in what we're seeing, now those go into play in 2014. What we're seeing leading up to that is stuff that you guys have mentioned in your practices. What we're seeing is that premium, that maybe you all are seeing it as well, premiums are going up in general. Their understanding is that premiums are going up in order to come under compliance with the coverage that's mandated. Premiums are going to go up. They're going to become more expensive for companies. My understanding of the way it's going to work is that as it's going to hit a certain point where the penalty for not offering insurance to your employees is actually going to be less than offering the insurance. So, employers are going to take the penalty, employees are going to be left with whatever is in the state exchange, which most likely is going to end up being the government, I would think. That's actually kind of a question. But it depends on the state. Okay.
In Connecticut, it's going to be Connecticut or Oxford HMO. Those are the two those are the two plans they decided were the base exchange. That was going to be the exchange. Those two plans.
So we're going to, you know, so you are not able necessarily to keep the plan that you have, number one. And number two, we start seeing a diminishing of choice in the types of plan that you can buy into. And I think at the end of the day, I wouldn't be surprised if you end up with a two-tier system, either the concierge care system and the government system. It's not going to happen overnight. It's going to take a while to get there. But we are on that road. There's absolutely no question that we're on that road. And I think that, you know, our health care system is not perfect. It has problems. I don't really think that this legislation addresses the problem of cost containment. And I think that there could be another way of addressing these, especially since when this legislation was created, none of the 18 physicians that were in Congress at the time, 0 of them were even asked to walk or even listen in at the door or given a memo for their opinion to, you know, like, what do they think would work? Nothing like that. And for the commentary that the AMA gave its approval, the AMA, for those of you who don't know it already, the AMA represents about 11 to 15% or so of physicians. Most of those are academics or academia, whatever the word is, and people who run the Medicare. In other words, they are actual government employees. So, you know, I don't really think that they give. You're asking the government employee if they like the plan that expands the government. I don't think it's, you know, it's not really an opinion that's going to be looking out for you. So that's what I can offer to this conversation.